I would like to welcome our next speaker, Dr. Mazen Bishtawi. He is a consultant subspecialist in gynae-oncology and minimal invasive surgery, Associate Professor, College of Medicine in Qatar University. He is the chairman of Ops and Gynae Department at Al Ahli Hospital. He will talk to us about adnexal mass in young patients is a clinical challenge. Please, the mic is all yours. Welcome in Palestine.
Thank you. Thank you, Sama. I'd like to thank the organizing committee for inviting me for such a great meeting, and I really would like to congratulate you on such a great meeting. Already I can see the success is there, so thank you very much about it. So today I'm going to talk about a assessment of adnexal masses in younger age group. Which one? PRC, yeah, that's the one. So when you're faced with a young patient, whether she is planning to get pregnant, whether she has a family or not, whether she is very young, and you face these situations, you really do want to know whether to go for surgery or not to go for surgery. So I'll try and go over the basic principles. So the outline of my talk will go through a general overview of ovarian masses. We'll go into whether shall we use biomarkers, or shall we use ultrasound scan alone to differentiate between benign and malignant? And I'll talk about some mathematical models like logistic regression to Adnex and the ORADs. And I would like to start with a take-home message. I think it's time now to move into one of the models when you want to assess those adnexal masses. So if I start with a clinical scenario, a 32-year-old lady come to your clinic, newly married, she's nulla gravida, she had an incidental finding of adnexal masses. So what sorts of blood you will do for this patient? So the RCG guidelines suggested that if it's simple, you don't need to do really CA125, but if it's complex, you do CA125, but in addition, you have to rule out other germ cell tumors, LDH, alpha-fetoprotein, and HCG as part of the follow-up. So you do the ultrasound scan, and that is the ultrasound scan finding. Remember, she's 32, nulla gravida, and you do a CA125 and it's 400. So what's your next step? Shall we go and remove the ovaries, or shall we go and remove the cyst? Before I move on, I would like to ask you, do you routinely do CA125 for complex ovarian masses? Yes, most of us we do. Do we think that CA125 is a good marker? So yeah, we have that kind of mixed feelings. I'm a big fan of the CA125, and I think CA125, a single reading maybe is not enough, but the CA125 has a classical graphs. So if the CA125 was high and continue to be high, that's benign. If it's low and continue to be low, that's benign. If it's high and start to drop down, that's benign. So the curve of CA125 can give you an awful lot of information. The only curve that you should be worried about is when the curve of the CA125 starts to go up and increasing and only in one way. That's when you need to worry about. But a flat CA125, you should not be worrying about. For so many years, we have been using the RMI. I stopped using it for a very long time. It's a combination of ultrasound markers, menopausal status, and the CA125. And I would like you to remember these figures. For the RMI, the sensitivity is 78%, specificity 87%. So please remember these figures, so when we compare it to our mathematical models. So this is one of the old studies in King's College. If you wanted to screen the general populations, you will find a lot of women with incidental findings of complex adnexal masses. You will need to operate. If you want to operate on all those patients with a complex adnexal masses, you will need to do 50 unnecessary operations to save only one case of cancer. And I see a lot in the Middle East, people just trying to treat pathology. So whenever they have any complex masses, they will just go ahead and jump and remove it. And I don't think this is right. I think those kinds of, the word complex adnexal mass maybe is not a good term, because a cyst with a multiloculated and a solid component should not be treated like one with a bilocular cyst and there is anechoic cyst inside. So does the ultrasound scan matter? Yes, it does matter. So you really need to differentiate between the likelihood of malignancy, a benign and a simple cyst. So we wanted to standardize our ultrasound scan features. When you do a laparoscopy, many times you have a look, you think, oh, this is just a corpus luteum, this is nothing, or this is just an advanced cancer, let's move on. But many times you end up having a cyst that you don't know really what's inside it. What shall I do? There are implications, because if you think the risk of malignancy is very high, those cases should be done by a gynecologist. And the literature on and on and on says that those cases with a high risk of malignancy, their survival is much higher than those cases done by general gynecologists. And believe it or not, even the very complex case, if it's done by an average general gynecologist, they will have a much higher survival than if it was done by a surgeon. It's not the procedure itself, it's understanding the disease, the progress of the ovarian cancer, that's what matters. So it's not about just only doing the surgery. Some people would say, oh, if it's complex, we'll take the patient to theater, we'll do a frozen section and decide accordingly. But that's not a good way. And it's been a long, long time since I did my last frozen section because of the underdiagnosis of borderline ovarian tumors and the underdiagnosis of carcinoma as a borderline tumors in around 30% of cases. So we go back now to ultrasound. A long time ago, more than 30 years, Sassoni was trying to classify those Adnexal masses and see what are the worrying features until the IOTA group came in 2002, and they are producing their recommendation on an annual basis. So the IOTA group, they were trying, when they do ultrasound scan, you try to classify your patient, whether this is a normal ovary and no further action is needed, or this is just a functional cyst, or this is a benign, borderline, invasive, and metastatic. And many times, it will give you figures about what are the chances of benign or malignant. So if we look at generally about ovarian cysts and tumors, we know in premenopausal women, the risk of invasive carcinoma is low compared to postmenopausal women, but there is a large group of benign and borderline ovarian tumors. So before we go further, we needed to agree on some sorts of terms. So if we look at a lesion, what do you mean by a lesion? A lesion is something that is inconsistent with the normal physiology. So a small corpus luteum cyst less than 3 centimeters, this is a normal finding, so it should not be called a lesion. The other thing is, how can you differentiate between a solid component inside the cyst or a blood clot? Because on the ultrasound scan, they can look alike. There are a couple of things that you can do. Either on a vaginal ultrasound scan, you just push on the ovary, and then you can see if it's a blood clot, it will start shaking from one area to another. And if it's a large clot, you can just run your color flow, and you will see whether there is any flow inside or not. There is no flow, that's just a blood clot, and it's not classified as a solid component. Again, when we see a dermoid, this is just a ball of hair, a hyperechogenic area, whether this is a partial or a complete, the ball of hair is not considered as a solid ovarian tumor. A septum is something that has to go from one side to another. So a partial septum, almost certainly, this is a fallopian tube lesion. So if you see a large distended structure with a partial septum, this is a hydrosalpinx, and this is not an ovarian cyst. So septum has to go from one to another. The basic principles of the IOTA classifications is the risk of cancer with a unilocular cyst is less than 1%, compared to a unilocular solid, around 33%, a multilocular cystic, a multilocular solid, and a solid ovarian tumor. The American College of Radiologists, they have published their guidelines recently, 2022, and they further subclassified into a unilocular, a bilocular, and a multilocular, and they think that the bilocular cyst probably has a low malignant potentials. So the cutoff for surgical intervention is 10%. Anything above 10%, you really have to do something about it. Any risk less than 10%, you have to take it within the context of the picture. Someone who is a very high risk, family history, or a previous history of cancers is different. So when we talk about papillary projection, what do you mean by papillary projection? It's a growth from within the cyst that has to be more than 3 millimeters. So, and the way we measure it, we measure the maximum dimension, the maximum depth of the lesion. So if you look into this graph, all of these are unilocular cysts. So you can see it's only one locule. And all of these are unilocular solid. Even sometimes some radiologists will describe it as a cyst with a daughter cyst inside. That's a multilocular cyst. Again, a multilocular solid. A solid, if it's more than 80% solid, it's considered as solid ovarian tumor. Now, when we talk about smooth or irregular, do you mean the inside of the cyst or the outside of the cyst? Well, again, it depends. So if it's a cystic structure, we're talking about the inside of the cyst. If it's a solid tumor, we're looking at the outside of the cyst. So when you say it's an irregular cyst, it's usually the inside. And you can see here, this one, this is the inside of it, and the other one is the outer part of it. And we comment on the content of the cyst. So either it's ground glass appearance, or it's like a hemorrhagic cyst, or like an endometrioma. So assessing a complex ovarian cyst, it's like doing a level 2 ultrasound scan. Take your time, have a look at the measurements, look at things, investigate, run your color Doppler, do things properly before you come up with the percentage of cancer. So a cyst content, again, it could be just only hemorrhagic cyst. Or it could be shadowing, and the shadowing can be diffuse or regional. And shadowing is a very good sign, and usually you see it with a dermoid cyst or any other fibromatous. When we talk about ascites, fluid in the pouch of Douglas is not considered ascites. The fluid has to be above the pelvis and usually above the level of the fundus. So fluid down there is not considered ascites. And color Doppler, not all machines come with color Doppler, so color Doppler is optional. If you have a color Doppler, please use it on and on. If you don't have it, there is another way of going around it. And the color score, it's easy. Score 1, no flow. Score 4, high flow. And in between, little flow and high flow. And I'll show you a little trick how you check for your Doppler, because many times you run your Doppler and everything is red, and sometimes nothing is happening. First thing, your machine has something called PRF. It's a pulse repetition frequency. So first thing, you have to fix it at 0.3, because the lower you go, you will see very high flow, and the higher you go, you might not see flow. So first thing, you fix PRF at 0.3, and then the next step is you play with the gain. So you play with the gain until you are satisfied with the vascularity, and then you can only check the flow within the ovary. Once you've done that, we go by something called simple rule. And the simple rules, if you have at least one of the benign features and absence of the M features, that's almost certainly benign. If there is a M feature, one M feature, and no B feature, that's almost certainly malignant. But if you have one feature M and one from the B, it's inconclusive. You can't make any decisions. And again, you don't have to remember them. There's a very easy way to do that. So by just doing an ultrasound scan, just by the ultrasound scan, you look at the simple rules, the M rules and the B rules, and you look at the B rules. You know, the M rules, ascites, solid component, papillary projections, multilocular solid, and strong blood flow. You will be scared when you look at those kind of cysts to send the patient home and do nothing about it. And the B rules are like unilocular cysts. It's only a solid component less than 7 millimeter, smooth multilocular less than 10, and no blood flow. By just looking at these rules, we look at the sensitivity and the specificity. Do you remember for the RMI, what was the sensitivity? Yeah, just by the simple rules, ultrasound scan, without even doing the CA125, you can achieve a 95% sensitivity and a 91% specificity. And because it's a busy lifestyle, if you don't see these patients very often, it's very difficult every time to have that sheet beside you. So the IOTA group came up with the LR2. It's a logistic regression curve looking at, initially it was 12 parameters, but they managed to reduce them down to 6 parameters. And most of the machines now, you select gynecology, you select Adnex model, you will just feed your data, and the machine will be able to print for you the possibility of malignancy. You print it out, and you counsel your patients. And so we look at the LR2 and the Adnex models. This is just a meta-analysis. I'll just skip through them quickly. And if you want to compare the RMI with the LR2 performs far better. If you look at all models that have been used before, like the Prompeller or the artificial neural networks or other things, you will find that the simple rules will have a very high sensitivity and specificity. I will not go through the HE4 because most of the studies confirm that HE4 does not add to the prediction, especially in experienced hands. And the CA125 as well, really, on itself, does not add much because all of us know that the values are overlapping. If you have 50% of women with stage 1 ovarian cancer, they have a normal CA125. In one mathematical model, they calculated the amount of tumor that secretes a CA125. So a 1 centimeter tumor will secrete around 13 CA125. So if the CA125 is 13, you already have a 1 centimeter tumor in the ovary, which is stage 1, which can be detected by the ultrasound scan. So I hope I can convince you to start using the Adnex models. However, back to the CA125, this is one of the cases from the UKC talks when they were doing screening for ovarian cancer. This is a patient who has been on screening. The CA125 was around 7 to 8 and continued in screening, and suddenly it moved from 7 to 8 to around 12. And again, that is significant. From 7 to 12, it's almost doubled. So they kept the patient under observation. The CA125 kept going up until it reached around 21. So 21 from 7, that's threefold increment in the CA125. At that stage, they did ultrasound scan. It was completely normal. So the patient was continued surveillance, and 13 months later, she had an adnexal mass operated upon, and it was stage 1C ovarian cancer. So you had at least around 1 year between the start of the increment of the CA125 before it changes into cancer. So if for whatever reason a patient comes to your clinic with a raised CA125 and you do ultrasound scan and it's negative, what will you do for this patient? Please bring that patient again. Don't send her for routine. Just bring her after 3 months or 6 months, do another CA125, do another ultrasound scan, and only you can tell after that. So again, let me remind you of the rules of malignancy, the ascites, solid tumor, papillary projections, and more than 10 centimeters multilocular. And I will just, for the sake of it, the other thing I would like you to sometimes there is something called pattern recognition. When you do ultrasound scan, this is hemorrhagic cyst, flip, move on. This is just endometrioma, we know, move on. This is just a simple, like this one, it's a follicular cyst, small anechoic cyst, chance of malignancy is less than 1%. This is a hemorrhagic corpus luteum cyst with a star shape inside. Again, this is a pseudocyst. You can see a normal ovary and cysts all around it. You can tell that this is a hydrosalpinx with a partial septi. So I will skip those lesions for the sake of time, and we'll move to the Adnex model. So the Adnex model, either it will be available in your machine, or you can download it from the Google Play or from the iTunes Store, or you can just go click on the web application. So you click on the web application, it will ask you these things: the age of the patient, whether you are a referral center, like I'm a gynecologist, a colleague saw a lesion, he was very worried, send the patient to me, that's still counted in the algorithm. And CA125, again, whether you have it or you don't have it, you will still have a result, and the 6 ultrasound value. So with the picture, the website will come like this. You just only fill this data, and you click calculate. And this is what you will get. So you print this out and you start counseling with these patients. The chances of that this lesion is benign, it's around 29%, and the chance of malignancy is around 70%. What will you do? I think this patient needs to be referred to a gyne-oncology center straight away. You don't need to mess up with that patient. And with all other lesions, so the 6 features that you need to check, again, these are the questions. So age, oncology center, maximal diameter of the lesion, maximum diameter of the largest part, more than 10 locules, papillary projections, less than 3 or more than 3, acoustic shadow present, yes or no, ascites, yes or no, and CA125. If you don't have value, just click and you will get that analysis. At least it will help you where to start. And if you look at the Adnex model and compare it to the RMI, you will see that the Adnex model performs really highest. And because across the Atlantic, our colleagues in the States, they like to have things different. They think that the Adnex model is too complicated for them. So they have come up with the ORADs. The American College of Radiologists, they published their guidelines in 2018 and updated 2022. And it's basically anything less than 1% is likely to be benign, managed, and low risk. Anything between 1 and 10% is called ORAD 3. Between 10 and 50% is ORAD 4 and ORAD 5. ORAD 0 is when it's inconclusive, you can't make up your mind. And ORAD 1 is when it's normal average. So 0 is inconclusive, 1 is a normal ovary, 2 is low risk, 3 is between 10 and 50, 4 and 5. And they added a little bit of data. So they looked into a early menopausal, which is 5 years after menopause, compared to late postmenopausal. So having a corpus luteum within the 5 years after stopping a period, less than 3 centimeter, can be observed. These are one of the changes, but it follows the same guidelines like the IOTA classifications and the descriptor, and they come up with the ORAD 3, and it's a full description, and I won't go into details of these ones, but they are more or less the same. They have incorporated the color flow. Remember, the Adnex model does not have the color and the Doppler as part of the equation, because many of the gynecologists, they don't have Doppler on their machines. And we talked about the binocular. So this is how you classify your patients into almost certainly benign, low risk, intermediate risk, and a high risk group. And again, so this is how you classify your patients. Step 1, you do ultrasound scan. If it's a normal ovary, that's it. If it's a benign, if it's more than that, then you look at the stratification models and you take it from there. Does it really matter between ORADs, GI, Adnex, and those things? Most of the studies concluded that they're more or less the same. At least find something that's suitable for you, easy for you to remember, and you take it from there. So in my conclusion, the standardizations of ultrasound scan reporting, it improves communication between your colleagues. If someone is calling me, I have an ORAD 5, I will be scared straight away. I will see the patients, as opposed to someone is telling me this is ORAD 2. And really, it doesn't matter which one you use. But the Adnex model, it will give you a percentage of whether this is a metastatic, whether this is invasive cancer, borderline, and benign. So it gives you more insight into that. And thank you very much.
احنا سعيدين جدا بحضورك وبعلمك دكتور، تشرفنا بجينتك، بس نعطيك هدية بسيطة.